Hi, everybody. Thanks so much for joining in to another roundtable discussion of the Community Health Worker Systems Initiative. I'm here with Ash Rogers of Lwala Community Alliance, that works in Kenya. Thanks so much for coming.
Yeah, thanks for having me. I'm excited to be here.
Cool. So we're going to be talking today all about your experiences working in Kenya. Has been in the news of late because of some of the actions around the election. We're going to also be talking about Lwala and all the work that you guys are doing. But before we get into that, tell us a little bit about yourself.
Yeah, so my name is Ash Rogers. I grew up in Arizona, and as a young person, I was interested in global health and international development, and got my first opportunity to work in East Africa right out of undergrad. And my job was to both facilitate student volunteer trips, but then from the revenue of those trips to provide small grants to local organizations. And I loved the second part of that job, and was really inspired by local leaders and local movements, and really hit by the fact that so much of the impact on the ground is coming from these really localized efforts, and so few of the aid dollars actually flow that far down. So that was in Uganda, and I loved that. And I went to graduate school, and after graduate school, I did a fantastic fellowship program with Global Health Corps, and then worked with a private funder called Siegel Family Foundation. And Siegel Family Foundation funds organizations in sub-Saharan Africa, a lot of health organizations, and I think they do a good job of trying to do philanthropy right. And my job was to help build a due diligence process for their grant making, and then to hire an East African team of folks who would manage the grant portfolio. And in the course of doing that, I got to know Lwala Community Alliance. And I was living in Kenya at the time, had been really inspired by the organization, had met the founders, really believed in their vision. So I was interviewing for this job to help lead the organization, and I was very pregnant, and I was supposed to...
As opposed to just a little bit pregnant.
I was very with child, yes. It was like it was growing. And I was supposed to hear back on the board vote for my candidacy at 8:30 a.m. on September 30th, and I went into labor at 2:30 that morning.
Wow.
So I was in labor in an Uber on my way to the hospital to deliver this child, and took this call to hear sort of enough to know that I was being offered the position. And so I gave birth a few hours later, and I actually hemorrhaged postpartum, which was, for me, quite a traumatic event, and it's one of the leading causes of maternal death in Kenya and in many places of the world. And so it wasn't lost on me that experience that sort of happened at the same moment that I also sort of took up this mantle to be with Lwala. And I know that we'll get to this, but our work is really about supporting mothers and young children, and to sort of be able to represent that in some way on a personal level as well has been...
Wow. Well, that's fascinating, and definitely we want to get into how Lwala is working, but just to reflect on that for a moment, that personal experience with health and disease and then opportunity to get health care, I think is what drives a lot of people in this work and often renews their interest in it. And this is not just people in the global north, but in the global south, because there's inequity everywhere.
Yeah.
People say, wow, this saved my life. Why isn't this available to everybody? Aren't we all human? Don't we all need this? And then you look and you say, well, it's not there. So you had that incredible experience, and you then started working with Lwala. So tell us more about what Lwala does.
Yeah, and just to say, no, it's true that the need for healthcare is universal, right? And it is something that can really connect us to each other. Motherhood is so universal, and it's just this tying experience of femininity, and yet we have such different experiences with it based on where we're born. So I think that really does tie folks together who are interested in this space and interested in global health.
The lottery ticket of outcomes, right?
That's right.
Where you were born, and we'll see what happens. Wow.
Right. So, Lwala. So, Lwala was founded by a community, a village that's called Lwala, a little more than 10 years ago, and they were in the midst of a dual crisis of HIV and maternal mortalities. And ARVs had been available, but actual access was really limited. And there was this village out in Western Kenya that had very limited access to any health services. And so they came together to build a health clinic, and they had donated community land and community resources. They'd found an architect. They had drawn up blueprints for what they wanted this clinic to look like. And 2 weeks before the groundbreaking of this clinic, the chair of the committee passed away. He died of HIV. And his two sons, who had their own really miraculous story of making it to Dartmouth and then Vanderbilt for medical school from this very poor village, came for their father's funeral and found all of these plans in place and committed themselves, and then by effect a whole bunch of folks in the U.S. to help fulfill their father's dream. Wow. And so they built that clinic, which today is a hospital. We serve about 50,000 patient visits a year. And then around that, we have a very holistic program that's built upon a community-led process of engaging community committees to create their own solutions. And that includes a large community health worker program that primarily recruits from traditional birth attendants. And then we also work in 13 government schools with health as our primary outcome, but working through the education system to promote health as well. And we work with some partners on economic development. So we work with a really great organization called Village Enterprise that has a poverty graduation model. And so that then runs alongside our community health model.
So you have activities throughout the value chain of poverty alleviation, from social determinants to then care delivery to extensions to the community, and then other programs to further engage with folks. So tell us a little bit about the scope and scale of it, and then through the years, what's that looked like? You know, when it first started, how many patients or clients was it working with, and then through the years, how has it grown?
Yeah, so early days, this was a clinic that was built by a village of a few hundred people, and today we serve somewhere between 30 and 35,000 people in this catchment area. And like I said, we do about 50,000 patient visits a year, and those patient visits come from far beyond our original catchment area, this catchment area of about 35,000 people. But the ambition for the future is much wider. So Vanderbilt University has been our research partner nearly from the beginning. And because of that, we've been able to collect some great data. And we have 2 studies that we've completed recently. One is of our maternal health outcomes, and the other is of our child health outcomes. Our maternal health outcomes, we have nearly 100% facility deliveries. We've seen a 300% increase in family planning visits over a 3-year period, with no change across 12 control sites for that same period. And on the child health side, maybe like most exciting for me, is that children in our catchment area are 64% less likely to die before the age of 5 than children from the rest of the region. And so the Ministry of Health has asked us to expand particularly the community health portion of our model, so how we work with community health workers and how we engage government facilities, have asked us to expand that to the entire county that we're within. So that's 1 million people in Migori County. And so our ambition is to reach this 1 million people in Migori County and build a county model of community-led health, and then have that be a model that we could share with other counties in Kenya.
So that story about expansion is a really important one to consider and understand. But first, let's zoom back a little bit and think about how you guys were able to get those very impressive numbers. Because there's a lot of community organizations that are active, but they're not able to quote the numbers that you just quoted. One, women engaging in facility births. A lot of people will say, well, it's against their culture. Yet, if culture were something that were static,
Sure.
you changed it, and now what happened? You changed their culture?
Sure.
Something happened. So let's talk a little bit about that mechanism, the reduction in under 5 mortality, improvements in care delivery. What did you guys do that drove that change?
Yeah, so the hospital opens in 2007, and they build a maternity ward in 2010. And the community was really expecting that, you'd build this maternity wing, and then you'd see this huge increase in facility deliveries. And before the maternity wing, about 26% of mothers were delivering with a skilled attendant. And after they built the maternity ward, that next year, that rate was about 46%, which is great. That's a big increase, but it's certainly not everyone, and it's less than half of the people, and yet that the physical access of a facility is there. And so this community committee came together again. We're sort of investigating this and started interviewing traditional birth attendants, and realized that there was this entire cadre of health workers that are serving people in their homes and have been for generations, but they have been left out of the formal health system, and in Kenya and in lots of places in East Africa actually criminalized for the work that they're doing. And so Lwala said, well, instead of trying to fight against these people who are actually just incredible women who have a gift and a desire to heal, let's bring those folks into the formal health system. Let's get them the training that they need to help assist families in the way that they want to, and invite them in to the hospital setting and allow them to accompany mothers in a safe clinical setting. And so that's what they did, and that was the start of this community health worker program. And so in that next year, after starting the community health worker program, which at that time was just around tracking pregnant mothers, that rate went up to 90%. And then over the last several years, it sort of inched up to nearly 100. But I think that that's really the key piece, is both taking a solution that's being developed by the beneficiaries of that solution. And sort of the genius that comes out of that is to see that traditional birth attendants can either be your largest competitors or they can be the largest champions of health. And that's where I think a lot of our other outcomes cascade from. So you have a skilled delivery. So then when this person who you really trust comes back and says, would you like to try a contraceptive method? That's a much more easy conversation to have rather than this outside person saying, can we sterilize you, right? And similarly, then that community health worker comes back and encourages you to get your child immunized, or encourages you to take your child to the facility if they have a fever, or is able to test them for malaria in your home. I think a lot of our outcomes really cascade down from that.
This is a topic that we've talked about often on these roundtables, is this question of generating trust. And now trust becomes this sort of lifeblood for invigorating and improving programs. But trust is not easy. Of course, some people will say, with an anthropologic lens, oh, well, they're people from the communities, so if they're talking their talk and walking their walk, they're more likely to trust them. But there are lots of programs that say, okay, traditional birth attendants, if you bring women to our hospital, we'll pay you. And they do, and the women have a bad experience. And then you've broken trust on both sides. Trust for the system, and now trust for the TBAs, the traditional birth attendants, where you find that the traditional birth attendants are now pariahs. They sold out. They got a cut to manipulate the woman into bad care. And there's lots of examples, which I won't, go into or name names, but that's a real danger.
Sure.
So that didn't happen with you guys. Your trust entered a virtuous cycle in which each year, little by little, you got, asymptotically to 100%. Actually, you actually got there. So what was the difference there? What did you guys do? Was it the quality of the care in the facility? Was it something about the way that your clinicians were providing care?
Sure, but I also so yes, and we have a quality of care regime that we do within Lwala Hospital that we think is important. But in addition to that, we've employed a cadre of traditional birth attendants at the facility itself. So in addition to having these community health workers, we also have what we call Mama Salamas, who work in the health facility every day. And they sort of help keep the area clean and support nurses with sort of administrative tasks. But then they're also this friendly face. They can sort of create a buffer for more patient-centered care. We've realized that it's really tough to teach nurses and clinical officers to practice medicine in a completely different way than they've been taught in all of the formal health system. And so there's lots of things you can do to improve that, but that having this buffer at the facility itself, we think is sort of an important sort of component of that. And this is actually a question that we're really trying to figure out right now, because the work that we're doing, we already work in 2 additional government facilities, and we'll be working in 3 more next year and many more the years to come, and are trying to figure out what is the minimum level of quality that needs to exist within those health facilities before we should even start recruiting community health workers or having people referred into facilities. So what's that minimum level of care that needs to exist to set up this virtual cycle that you're talking about? And we think part of that is actually employing 1 or 2 traditional birth attendants to actually be within the facility. But another part of that is actually just making sure that there's commodities and equipment and folks are trained.
I want to highlight that because I think that those are 2 really important take-home points for folks listening. One, this question of a patient-centered broker, really focusing on patient-centeredness. I mean, they often talk about the components of quality care are not just clinical effectiveness and efficiency and safety and accessibility, but also patient-centeredness. That's another universality, right? We say all people should have access to health care, but shouldn't we all have access to health care that treats you like a person at the center of that care, not just a recipient, impersonal? I would want that. A woman in Kenya would want that. I suspect everyone that's human on the planet will want that, regardless of culture. Then the other question of this thresholding function, how you want to make sure that you cross certain quality and, I guess, sort of product delivery, to use market logic language, but a sort of, you want to assure that something is actually there before you start offering it and making it widely available, because maybe there is danger to launching too early. So that's fascinating. But so how do you guys know? I know you say that you have people there that they're going to be sort of helping you understand, no, this is ready for the people, but do you have KPIs, the key program indicators? Do you have an analysis program? Do you do like a lot quality assurance sampling? These are all techniques that people have used. But so what do you guys use as your litmus test for we're ready to go live?
We've been building out a quality assessment tool, facility quality assessment tool that with a partner called Health Builders. They work in Rwanda with Rwandan government facilities, and trying to take some, and their assessment tool, which is really interesting, is really focused on management systems at the facility rather than clinical quality. So things like procurement and data collection and staffing and the more sort of and patient flow, things all around actual care that make a big difference.
To patients in particular.
Exactly.
Stock outs, do I have to wait 10 hours?
Totally, and it has a direct impact on whether or not what your health outcomes are. And then combining that with some Kenyan focused tools. And the WHO has great tools for this. So we've sort of pulled from different components like that. And so the idea is that we have this quality assessment tool. I should also say that before we go into any government facility, we organize what's called a health management committee, which is a community structure. And so we're really focused on making that community structure as participatory as possible. So there's a broad base of community members who are involved in that committee. Then we go in and administer this tool that's really a self-assessment. Then clinicians are sort of using and filling out, and then sharing back with that committee. And then that leads to a plan that the facility engages on to improve quality of care. And then they set out some like benchmarks that they want to hit before the start of the community health worker program. So sort of like a long-winded way to say that like it's complicated, and we have basically like a really large assessment tool with lots of different types of indicators around it. But we haven't figured out yet, like, are there some like really proxy indicators that if you have A, B, and C, then you're good to go?
It actually sounds quite elegant to me, in the sense that you have, key functions that then will produce information and decisions that help you then grow intelligently. I mean, people do much more complicated and less effective things. But one thing in particular, because one of the things that I've seen a lot of people struggle with, and I think folks listening will agree, engaging the community effectively.
Yeah.
Actually getting the community to participate in that committee, participate well, whatever that means, and who decides what good participation looks like.
And who should be participating.
And who in the community should be participating. And also, when we say the community, in a lot of these contexts, there's many different language groups, religious groups, social stratification. Humans love to do it, right? We love to divide ourselves up by he said, she said, we said. So how do you manage that? And what have you guys found are some of the, take-home lessons for doing it well?
Yeah, I think a couple things. One is that it's easy, this idea of having like local champions, because it's less people and you can sort of trust one person rather than trying to figure out something that's really messy and complex.
Like a giant assembly or something.
Or like you just trust the village chief, right, which in Kenya is often, it's a political position, right? And so your chief may or may not actually hold local legitimacy,
right,
and they have a constituency that is not everyone.
And special interests.
That's right.
Yeah.
That's right. And so one is like being intentional about having lots of time to convene lots of people and making sure that those committees are diverse. Yeah. And then the other thing that Lwala does is that I always say committees, because we have like this health management committee, which is like an official structure around the health facility that's part of like the Kenyan structure. But then we also have all of these other types of committees. So we have a sexual and reproductive health committee. We have male forums, which are men only. We have this mentorship group that's only women. It's for mothers and adolescent girls. And so that's the other way that we sort of try to address that, is to be really multifaceted and have several different types of ways that people can engage.
And what I'm hearing too is, when you say being intentional about the time, in my implementer programmatic hat, I hear you have to budget for it, right? It's not just, between lunch and tea, we're going to, maybe meet with some folks. Is that you've dedicated a position to engage, liaise, connect with, meet with, sit down with, get to know. That person has to be retained long-term, or that team needs to be retained long-term, so you want to give them a real job. And all of that.
And build patience with your funders, because you don't get like great output indicators while you're engaging,
right,
while you're facilitating. Those aren't great. It doesn't like come out well in a nice report.
It does look a little bit like a lot of expensive overhead for process.
Yeah.
But right, then when it's all said and done, you can say 100% of our people come and get care here. A lot of them don't die, and a lot of their kids don't die. So that's pretty impressive, versus, when we say, well, I'd rather spend just a little bit of money and make sure it's cost effective, but the outcomes are terrible. So it was cost effective because it was low cost and low effect.
Yeah, exactly.
The ratio was perfect, right? Versus
costs you very little to do very little.
Yeah. Right. So then why don't we actually get something done? And how do we actually do that? But so it's a budgetary question, and you guys have created a huge amount of experience that we could learn from. But this budgetary question is a tough one, because budgets in the world we live in are limited, and funders do have priorities They also want to see results within a time frame. And then on top of that, if you're thinking about growth, you guys have a plan to get out to a county level impact. You know, as they say, small is pretty, but big is necessary.
Mm-hmm. That's right.
So there's a trade-off there. How are you guys beginning to think about and navigate those trade-offs, especially now that you're positioned to grow?
Yeah, I mean, I think the first is I would just sort of push a little bit and put like some numbers out there for us.
Yeah.
It costs us $12 a year to support a mother throughout her pregnancy. I don't know that that's that expensive.
No, it's not.
So I think one is that it's not $2 per capita, right? It's not 50 cents per capita, but to be able to save a mother's life and save her child's life, like that sounds pretty great to me.
Yeah.
And so one, I think, and I know that you believe in this, but is like redefining what expensive is, and thinking about, like, it's important to know our cost per beneficiary and the cost to deliver a service, but also to put that in the wide scheme of this is saving lives, and we should want the very best care that we can possibly provide to folks. That being said, I think that when we think about our growth strategy, we're going down 3 different pathways. One is to expand our direct service delivery. So we're currently serving, like I said, about 35,000 people, and we're going to expand that to about 150,000 over the next couple years. And that's done in partnership with government. They're paying for some things, we're paying for some things, but it's definitely going to be the most robust version of this model. But to be able to go beyond that and reach this million, then we're also working with other civil society organizations within the county. So these are other local organizations who are already doing health work, who already have that community legitimacy, that local level trust. Their participatory mechanisms might look different than ours, but they know those localities really well. And so working with them to be able to replicate the most essential components of our community-led health model while we support the Ministry of Health at a county level to set the right health policy and the right health structures to be able to hold up the model countywide. So we're thinking about how do we sort of leverage existing resources and the existing infrastructure that's already there.
It's fascinating because if I were to picture it graphically, my mind's eye, what I'm seeing is a model of infectivity, which is where you guys are there. You're now a hot rock example. You're a sort of a nidus, and you're starting to spread out by these contacts. You're touching new groups. You're incorporating new groups. A sort of spread, a good infection, so to speak.
Yeah, I like that.
As opposed to the way a lot of global health is done, is that people say, hey, we did it at this little corner of the world, so therefore let's bring it back to the metropolis.
Yeah.
Let's say, dear government at the central level, you have to fund this, create the funding. First thing they do, they say, oh, by the way, it's way too expensive because we want to spend $5.
So let's water it down.
Yeah. What can you cut? Can you cut these community groups? We know they don't do anything.
It takes a lot of time.
Yeah, that takes a lot of time. And that's expensive. Can you cut these women in the hospital? What are they doing there? They're just drinking tea. Come on, you know it. So what we'll do is, and the doctors and the nurses want a new, facility for their breaks. So we're going to put that money instead. And there's this very messy sort of process of when it goes to the metropolis and comes back down, it often doesn't hit in the same way.
That's right.
There are examples where it does work, because largely when you have a very powerful central government in a small country. In other places, a very big, complex country like Kenya, Nigeria, Mexico, name your country, South Africa, there's these other models. So what lessons do you have when groups are like you and they're on site and they're smart and they're doing great stuff and they want to expand, but they want to go through this positive influence infectivity model, but then also see opportunities for central influence and sort of raining down benefit model?
Yeah.
What advice would you give groups like that?
Yeah, I mean, I think there's a lot of wisdom in what you just said, and I just want to underline it a little bit too. It's like, Kenya Kenya has like 48 million people and 68 different language groups, and it has savanna and jungle and coastal cities, and it has arid lands, and the population densities are super different, and it has one of the biggest slums in Africa. So it's incredibly diverse, and to think that you're going to build one community health model that is going to serve all of those different environments, and that's going to be a top-down, nationally scaled idea is ridiculous. It's no wonder that when we try to have these nationally scaled programs that we're finding a lot of failure, and that we're finding a lot of spots where we're not getting the health outcomes that we want. And so I think instead we need to think about scale from the perspective of how do we strengthen bottom-up processes so that local solutions can grow outward. And that means, Lwala's strategy, for example, we're still engaging with the National Ministry of Health, right? We still want to know what the national priorities are. Those are important. We want to support that structure.
Right.
We're also working at the county level with those officials. That's really important because we need that county structure to work for commodities to flow through the county, right? And for, we need to have emergency transport systems working, and you need to have referral systems to tertiary hospitals working. That stuff's important, and you have to engage on that level. But I really see it as how can you work at sort of the top level of policy making to create the operating environment necessary to allow local efforts to be effective. And so I think that should be the aim, rather than having a top-down sort of vertical solution that goes across these really diverse places. And it goes along with a movement towards decentralization that Kenya is going through with their new constitution, that's all about creating better structures for democracy to work. And we have sort of immediate health outcomes that we want to achieve, but long-term those health outcomes are incredibly determined by the level of democracy and freedoms that exist where we're working. And so while we're trying to deliver health outcomes in the short term, we should also be trying to strengthen democratic institutions so that in the long term those changes that we're making are sustainable and are solidified by a wider system that works.
It's fantastic. I mean, to bring up the issue of democracy, and democracy being government for the people, by the people, it really entails an engaged populace. And if you have a system where wisdom reigns from on high, that kind of in a lot of ways works against that, doesn't it? But instead, instead of wisdom necessarily reigning from on high, you have this enabling, empowering function. And what exactly that looks like can come in many different ways. But I think for our own experience right now in the United States, where whether or not you agree with what's going on at the federal level, what we've learned is what we're seeing is that there's this incredible opportunity to still get a lot done.
That's right.
At the local level. Everything from addressing climate change to voting rights to equity around gender, race, and class, sometimes even down to the county level, sometimes down to the corporation level, right? I think that a lot of corporations, even for-profit corporations, realize that dignified human flourishing, which is a lot of what we're going for, is just good business. It just makes sense to have an engaged populace that participates and is healthy and productive in life. That's a world where commerce flows, where ideas flow, where benefit flows. And I think that that's what the future, hopefully, will be more of, as opposed to the other options, which we're all sometimes scared of.
And I think a bright spot that we have that goes back to your previous question, too, is that we also have a ton of technology in the world that didn't exist before, that can allow that sort of that national, local conversation to happen easier. One of the things that I think has allowed Lwala to have a platform to say, we're this really community-based organization with this very sort of like niche solution. But what's allowed us to say, well, let's work with the Ministry of Health to actually expand that, is the fact that we just have really great data. And that data, our community health workers have tablets, and all of our data is individualized, and we're able to see it in real time, and our communities are consumers of that data, and they're looking at it and making decisions based on it as well. And so that the opportunities that we have to be able to get actual data points and like really good information from a community level and share that back with the community, but also share that with policymakers and have that cascade up, like that's something that, you know, until very recently hasn't been available in the world. And to me, like, I think opens up a lot of possibilities.
Knowledge is power, and knowledge comes from data. Data is power. That's I think that's another incredible take-home point. And also sort of speaks to why organizations should invest in a couple of things that you're pointing out here. They should invest in these engagement structures. They should invest in the systems that actually produce good clinical outcomes, and not those sometimes are not just clinical systems. And that they should invest in a system that allows information to flow and be usable, and that is ultimately used. Again, that question, let's just go back for a second and think about this question of what's expensive or not expensive. Because it is a fluctuating concept, and it's determined by a lot of ideologies that frame the question, as opposed to just pure cold math, you know? Right. This is our threshold and this is how much we have. Well, why is that the threshold? What macroeconomic policy has allowed that threshold to be set? And if you can't change the policy, what are other mechanisms to get money to flow? You know, no one in the 80s would have predicted that we were going to have a global fund and a PEPFAR. Heck, even in the 90s, we couldn't. Heck, even in 2002, we would have not predicted that we had PEPFAR coming.
Yeah.
Right? I mean, PEPFAR was a complete surprise for most people, but yet it completely changed the way that we engage and think about what's possible and not possible, and has single-handedly, along with Global Fund, saved a generation, even though there's more work left to be done. So let's say that money does come. Let's say that we have a reframing of the question in which we say, you know what, we're not interested in just meeting a $5 cap, but we're interested in trying to do the most that we can for the lowest possible cost, because you always want to keep it high value, you always want to be efficient, but we want to do the most possible to have every human being live a life that's dignified and can flourish, per their terms. What thoughts and ideas would you have that would work towards that? Of course, in addition to all the other things that you've been talking about.
Yeah, I mean, I think that's the sort of the other half of what Lwala is about. So we have this health program, but then with a very similar methodology, we're trying to seed resources and seed sort of a structure for communities to come up with other ideas and other solutions that can support sort of more holistic well-being. And so that's the work in these 13 government primary schools, for example, that are all built around community committees that are interested in that school and that come up with their own solutions, interventions that they'd like to do in their school. So let me give you an example. So one thing that we were noticing, we'll go back to the original story that I was telling about of trying to get the mothers into the facility and the idea with institutional birth attendants. Well, Lwala had achieved that. We were getting all these skilled deliveries, having better health outcomes. But what we were noticing now that we were getting everyone to deliver in a facility, that 40% of those births were by a teen mother. And so there's just incredibly high teenage pregnancy rate. And, of course, we all know that younger mothers have worse health outcomes and their kids have worse health outcomes. And so then it was saying, okay, why is this happening and where can we intervene to reduce the teenage pregnancy rate? And really identified that if we could keep girls in school for longer, if we could reduce the stressors that create a lot of transactional sex and coercive sex in our community, then not only are they having a better, more meaningful life because they have more opportunities, but also they're less likely to become HIV positive, they're less likely to become pregnant as a teenager, and if they decide to have children, those children have better health outcomes. So the community talked about these issues, and one of the solutions they came up with was to provide sanitary pads and latrine blocks within the school. And like in a lot of places in East Africa and India, girls have this really crazy decision point to make of whether, when they're menstruating, of whether or not to go to school, and having like the dignity to be able to go to school with a feminine hygiene product, and having transactional sex with a man who can provide feminine hygiene product. And that's the decision that a lot of our girls were having to make, which is just so much loss of dignity in that. There's just so much anger that comes from that reality. So Lwala started this social enterprise that makes reusable sanitary pads. It's now spun off. It's its own separate entity, but together with these community committees, Lwala procures reusable sanitary pads for all the girls across these 13 primary schools. It is incredibly cheap, if you want to talk about cost efficient, to keep girls in school. Wow. And created latrine blocks, which is also really important, so there's like a dignified place to go during the day. But I think that there's all sorts of ways there's all sorts of bright spots around the world of great ideas, of great things that are happening, and can we seed those in a really holistic way and help them expand out?
I love it. I mean, I asked you as experts, bearing witness now here in front of many at this podcast, what wisdom do you have? And you said the wisdom came from the community.
Yeah.
Because we listened. I think that's its own wisdom, is that I could have asked a lot of people who get paid very good money in a very nice consultancy jobs, and they would have said, conditional cash transfers. Mm-hmm. Or they would have said this, or they would have said that. And it's true that all that might be true. And
cash transfers are great, I would argue, because they allow local people to seed their own ideas. I think seeding resources is a great idea. But it actually is built off the point that people actually know what they're doing.
And so conditional, unconditional cash transfers versus, would latrine blocks and sanitary napkins work in every context? Depends.
That's right.
But it's that question of asking people, and then they will tell you their wisdom. I would have never guessed that. Although, of course, my bias is I work in a different part of the world where that's already provided by the government. It's going to be something different, right? But that listening to the community, turning that wisdom into action, for me, that's one of the great things that Lwala has taught us. And I'm indebted to you for coming and spending some time before your board meeting here in Boston. To come and talk to us. And I know everyone out there on chwcentral.org and with the Community Health Systems Initiative is also indebted to you. Any final thoughts before we close up?
No, this was great. I feel really privileged to be able to be here and to be part of this community. Thanks.
We'll build it together.
Cool.
Thank you.
Thanks.